So looking at him from the anterior view, okay, according to David McGee, we're looking at his ear pinna, his chin, his side jaws. We're looking at his SCM. We're looking at his clavicle. We're looking at his trapezius. We're looking at his shoulder level. Okay? So whoever is in line behind me, and if you want to shout out what do you see is abnormal.
You guys want to go first?
Larger on the left side of his body, in the trap.
Elevated on the left.
Yeah?
Yeah, on the right, and like I see, not from the front, but I can say that it's like more anterior, the right shoulder.
Yeah, he's built. Can you see the muscle mass difference?
Yeah.
Yeah?
I don't
Can
really
I
see
unvolunteer?
Can you unvolunteer?
I don't see muscle mass difference. Where?
I mean,
You don't see it.
In the upper trap?
No, the delt. The right
yeah, I
delt.
think the right delt is much larger.
Okay, yeah, a little bit.
You see it? So yeah,
mean,
so
I
it
see
is
that.
it is true.
Yeah.
So let's work on the skill part that. So what I'm going to try to describe. What tells me that it's bigger is if you see the difference, the diameter between his axillary fold to his outside delt, it's less than the right. Also, if you look at the contour of the
Yeah.
deltoid, it's flat. It just goes straight down from the clavicular acromion process to his first fold on the triceps. Versus right here, it's got a contour. Am I helping?
Yeah.
Cool. Alright, so yeah, whoever shouted trapezius, that is true.
I like your change in posture to show that little
Yeah.
curvature.
Yeah.
Yeah, like how much is that the way he's actually sitting versus true?
So, and I go through
Yeah.
that a lot, where
Yeah.
I look and I'm like, try to see what
Yeah.
I think I'm seeing. So like, when I look at first, say the pelvis, I'll have someone do a bridge and then check again.
Right,
Something like this, I would have someone reach up overhead
okay.
and then come back down.
Yeah, because,
And
Let
you do
them
a-
settle
yeah.
in.
Yeah, you do a reset of position where you have someone take a deep breath and force the exhale. And then so you can kind of get these reset buttons, and if you keep seeing it repetitively despite change of
okay,
motion, then that's a little bit more telling versus someone that just happened to be sitting this way. And that's-
Sure.
Yeah.
Or because I was
or the way
on the
you're
fold of it.
supinated, pronated with your hand, or,
Right.
right, okay.
Exactly, right, because
Yeah.
if I'm over
Right.
top here, then I'm gonna look more rounded. So I usually
Right.
try to go
Kinda
through a couple
neutral.
motions, and without telling them what I'm doing, I'll have them move and then reset and see if I see a pattern.
Okay,
Because even if I moved and you saw, like, oh, actually his left deltoid is as big, but if I've done it 3 or 4 times, even if it's not as big, there may be a functional component to the pattern with which I keep positioning myself, even if there's not a anatomical change or difference
Okay.
in that sense.
Yeah, I
Right.
think when we're communicating or when we're talking about something is also when I would notice like, okay, they have a tendency to shift their weight on one side or usually they bend their neck on a certain side. So I think that's when I'll get also a good idea of their posture.
okay. Just when you're sitting during the.
Just, yeah.
Anything else that you guys see, that I see
In what region?
in the front of the neck? The two muscles,
Scalenes or sternocleidomastoid?
SCMs, yes. So if you see the definition of the insertion into the clavicle
Yeah.
of the SCM, there's a difference. Which one's what?
Oh, it is.
Yeah, so the left one's more prominent, the right is more diffused.
His right or your right?
No, his right,
Okay.
his right.
He can't. You can't not do that.
Uh, No, it's not going to change because that is his posture.
Yeah.
It cannot change.
Yes, I see.
All right, second
Go
one.
point it out.
Point it out.
Yeah.
So it's this, and
Oh,
this
yeah.
is more diffused, and this is more prominent. You can actually feel
Yeah,
it too,
I saw, yeah, definitely.
right? This is more prominent. Alright, what does that tell you though? What does that tell you?
I would say not one thing specifically, where it may be more hypertrophy there. It could be a shorter muscle
Okay,
relative to the other side.
Good point.
It could be because of clavicular or scapular elevation on one side, so therefore that's causing an apparent shortening.
good point,
So I
good
would
point.
probably start looking for why. So I'd start to look at maybe getting ahead a little bit, but we'd do posture assessment from the lateral view
Yes,
first.
yes,
But then
yes.
I would take someone through cervical range of motion to see if it's impacting the kind of resistance, because if I'm turning, I'm saying it's as far as I can go this way, but I can turn all the way this way, then we know that it's a
It's
muscle
even more
length issue.
dominant, even more apparent.
Yeah, I'd probably look at how the first rib is moving.
Good point.
Because we
Okay.
know that that's gonna impact that as well. But probably the absolute next step would be a lateral view of the posture.
Okay. Yep, so we'll do next. There's one more thing that I'm seeing on the head position, the occipital position on the cervical spine that anyone can pick. That goes in congruence with the way how his left SCM is dominating.
So he's rotated,
Yes, which side?
he's rotated to
On the left.
towards the left. So
What
right
makes you say that?
rotation.
It's a right rotation.
Yeah, right rotation.
It's a right rotation, yes. What makes you say that?
SCM is on the left side more prominent.
Yep, that's one. Alright, so if you look at the jaw, if you look at his jaws,
It's
the
lower.
right one is less visible. If you look at the girth of the nose to the jaw is less than what you see on the nose to this jaw. The second is you cannot see the same amount of pinna on the right ear versus the left.
Oh, yeah.
The ear pinna.
Oh.
Yeah. And the third is the distance of his chin to his right contour of the neck versus the distance of his chin to the left contour of the neck. Do you see a difference there?
What part of this is like pathologic versus just normal anatomical variance?
Agreed. So I go by what the symptom is and what he came in for.
Okay,
So we asked he has a neck pain.
okay,
We asked he has a postural pain.
okay,
We asked his is not constant, it comes and goes, and if it triggers with sitting. So that tells me his condition is a lot more postural, and so I am very detailed on my posture
Okay.
for his case versus somebody who, like Kim, came in after had a tennis tournament, but also had a sitting aggravation, and her symptoms are mid-back. I'm not going to be too focused on how the neck is holding, but I'm going to be looking at how her nerves are, because that is how the pattern has gone into a thoracic spine, is the nerves are very overactive.
Right, or if it was, say I was getting sharp stabbing pain with, specific motions, right? When I turn my head to the right, I feel this stabbing pain, I'm immediately thinking vertebral and I'm not so focused on the small difference
Right.
in his
Yeah.
SCM
Right.
versus otherwise.
Yeah, that is a very good point, because I don't foresee him having a foraminal stenosis at this point, so I'm not going to worry about hypothesizing those things just yet. He is a younger individual than, let's say, Nanette, who we just saw, and I am already thinking vertebral foraminal stenosis, or when the chiropractor did the manipulation, that they may have impinged an osteophyte into a nerve. So I'm not even going anywhere there into bone. I'm all muscular, making him as an athlete and all of that. So, all right, so frontal plane, we're good. Well, let's go lateral plane.
Yep.
The other thing I know, also, you guys mentioned about the left trapezius, but it's also that his left clavicle is elevated. So that sets him up for, I don't know which side your pain is, so don't tell me yet. Let's see. So everybody, if you want to join me on this side. If you want to diagnose forward head syndrome, it's the middle of the ear to the center of the shoulder. And in his case, I think he's just too upright right now.
Not corrected.
But very well corrected. But otherwise, I know how he goes by. And so he has slight forward head just like I have.
Yeah.
And what else do I see from here?
It was
Do you see something in the upper chest? Do you see something in his top of the chest?
Like concave? Like,
Yeah, there's a dip. There's a dip. Where do you think it might be coming from? I see something in upper
Like,
cervical, thoracic. Yeah.
yeah.
Now how does the rib go? The rib go in a slanting downward direction. And so not only that he has started to have a little bit of rounding on the upper thoracic, but it is impacting his upper sternum and his first 2 or 3 ribs. And so he may develop some chest discomfort and rib pain or even popping or clicking or those kinds of symptoms. Some limitation is rotation is possible again because now we're talking ribs. And so checking the rib rotation and looking at those areas of concern.
We're also, we had just talked about with the SCM, so with it, basically the SCM coming down from the masseter and attaching at the clavicle and also the sternum. So if we're seeing that upper thoracic rotating, especially if it's unilateral, that can cause tension across the SCM or shortening there as well.
All right. So that is lateral. There is
I'm right in front of the camera.
posteriorly, I think, for people in the neck with neck pain, the only thing I'm focused on is the scapular positioning, and you can go detailed and make some pen marks. How do you feel about that, TJ?
Go for it.
Okay. Go.
It might be in Sarah's room.
Pens?
Yeah.
I've got some dry erase markers, it makes it easier.
Right, here it is. So
I have
Sarah, don't complain for us.
I have a mic.
It wipes off a lot easier than pens.
Thank you. All right, so going off of the spine of the scapula, so that's the spine of the scapula, and spine of the scapula on this side. What do you see?
So you already said it was
Yeah.
anterior rotation.
Yeah, it's definitely higher. And that, I mean, it makes it so obvious, just
Yeah.
making a couple
Yeah.
marks versus you're like still guessing, okay, is it there or not? So that's the spine. Right, and then that's the medial border, and that's inferior border, and inferior border.
It makes a huge difference being able to see that.
Okay,
Yeah.
so can you get a measuring tape, please? That's C7. E1.
This is dry needle and we drew everything. Yeah.
Ooh,
The Sharpie.
boy.
Shaj, you gonna help?
Oh, is that rain?
It's just air.
Oh, good.
Oh, I was like,
I didn't see it.
yeah, I thought the same thing.
No, it is rain.
Oh, shoot.
5, 6.
Oh yeah, I see it dripping now.
All right. What do you guys see?
Straight, yeah.
Sorry.
I mean, he's got it lower too. You can see it here too. Sorry. But doesn't he have hypertrophy on here anyways? And so we did that one position where you tilted his legs out and the opposite, or that direction to try and line it up, right?
Correct, yes. I would do that for if he had lower back pain, and I think he does, and we can go into that. But all right, so where's the measuring tape?
Oh, had it. That was good.
All right. So things that I usually see. This is all, I do it visually because I've done it enough that I can see that there is a difference in the width of the distance between the spinous process and the medial border and spinous process of the medial border. And the way once I pick that up, I already have formulated a hypothesis that he is weaker on his right. Well, there are two types of weakness: stretch weakness and short weakness. So he can be weak both thoracics the mid-scapulars, but definitely he is having the stretch weakness on the right side and short weakness on the left if he is weak on the left. And the way how I would diagnose if he's weak is doing the scapular MMT, which you do prone. Yeah, you can actually do that. So we go prone, yeah, so there are three major muscle groups that I like to test. One is the mid-scapulars, which is the middle of the rhomboids. Then second is the lower trapezius, and then third, rhomboids and mid-scapulars go hand in hand, lower trapezius. Actually, I like to differentiate between the mid-trapezius and rhomboids, just so I can figure out if it is an external rotator muscle group or an internal rotator muscle group. And rhomboids are internal rotators, so we can have him, differentiate that accordingly. So extension that he was doing, I like to use it, but I feel like it's not very conclusive to me, because there's so many influence from lats and triceps. But yeah, if you have any suggestions on extension, if you use it in certain way, shorter extensions.
I do not.
Yeah.
I go rhomboid, mid-trap, low trap, and then I do serratus as well. I think it's very important for
That's
different
right,
positions.
serratus. I think Farine knows how to check serratus because she was testing me yesterday. So from here, let's go middle trapezius, and I'll ask the patient to go into 90 degrees, and then squeeze the shoulder blades first, and then extend the elbow, and go full range while they're externally rotated, so the thumbs are up. And you hold, and don't let me push it down. So I'll measure with my strength on both sides. It's actually pretty good. The one thing I noticed with him building quality strength was, did you see the winging on the right scapula?
Can you do that again?
Let's do it again. So go ahead and scapulars, please. Alright, and then we're going to go 90 degrees. Okay, and we hold, and we fight. So he gives
Yeah, at the end.
on the right, but it also in the beginning when he was powering through, because he has the strength to do the trick movement, to
Compensate,
compensate. He has the ability to fool us in a way. But there are the basal support, he cannot maintain that. So then it's clearly that his right scapular, which we saw in the distance, he has a longer distance, so he has this stretch weakness. The other thing is, do you see in the sagittal plane, in the vertical plane, he has a spinal change, right? So his spine is shifted to the left, and what does that mean in regards to rotation of the spine? Which way is his spine rotated? If the spinous processes,
Yeah, right, rotation. If the spinous process are this way, then
so it would be rotated to the left if you look from the posterior angle. The point of reference is to be on the back. I think we're all thinking the same. I guess the
Yes.
directional is issue,
we're
which we can.
rotating to the
which we
left,
can-
yes. So the direction of rotation is the direction of the spinous process, not the vertebral line.
I always think of it as the composite result, which would be rotation to the right.
That's
If the vertebral body rotates left, then
That's right,
the spinous process rotates left, the composite action of that is right rotation.
That's right, yeah.
Okay.
He's right. The spinous processes are going to the left, but then the upper body is rotating to the right.
Yeah, so
Yeah.
it's right.
It is the right
Correct.
rotation. It is the right rotation. But again, coming back to clinical nuggets, does that even matter how we
No.
nomenclature it? But we do want to make sure that it is the correct side we're treating. Because yes, I felt that this goes this way, and if this is higher, then I'm going to do PA glides on the right side if that is the case. But if this side is what I feel that is higher, then I'm just going to move it. Because my aim is to go as neutral as possible, as for a spine, for a human, for a shoulder, for neck,
You
for
mean neutral, like fine-tuned it as possible?
alignment of even distance.
Oh,
or,
neutral, sorry, yeah.
even
Okay.
distance of the shoulder height and the neck and everything as neutral as possible. Now there are exceptions, like a golf player, in his case, a tennis player. And they don't need to get fully neutral, or else you're gonna mess up their game.
Okay.
Because they're gonna start to not
Right,
feel
that was a
the
good
way
idea.
they
I was
were
like,
playing.
yeah, maybe they
Yeah.
don't understand that or
Oh,
not.
that's
So yeah, when.
Which
when
is
we're
probably
talking
why
about
I'm partially
rotation,
rotated the way I am.
Yeah, it's rotated
Yes.
to the right,
this
but
part is to the right, and this part goes to the left.
So some of our brings up a great point that's
Because this is going left, but when you look at the anterior part, that's
that's
going
the
right.
direction of
To
the
the
two.
right.
Got you. Because this is where you see it, is
Yeah.
it moving that way. Gotcha.
TJ, here we go.
Yeah, so Sarvar brings up a good point. So with me, with my rotation being trunk composite towards the left, my vertebrae towards the left, as a right-handed golfer, that's where my rotation needs to be. So even in training myself, I
Left
work
rotation.
my
Right
mobility
rotation.
in this direction
Right.
significantly more. And I have pretty good, I would say very good trunk rotation mobility in this direction because of that relative to this side. I don't need to have as much of the activity, so I
Okay.
unilaterally train a little bit. Same thing with like my oblique strength. I focus more on my left oblique strength than my right oblique strength because that's the side that's going to pull me through on a swing. It's going to also do the same thing as far as
It's rotating.
yeah, exactly. So I think it's kind of a fine line to walk because
It is.
you have to determine where the person's at and are these positional faults causing pain. So for me, I would say my base analysis of myself is it's postural more in the sense of head posture and positioning and potentially low trap weakness and stiffness in my upper thoracic spine, more so than the rotation. I, working with myself, probably wouldn't do a ton to change that, knowing that not only am I a golfer, I'm also a golfer that is training specifically for the action.
Bye, Frank.
Thank you.
Where I'm training pretty specifically for the action, meaning I understand that some of what I'm doing is unilateral. Now, obviously not everyone, you're gonna see the PT that can explain that to you, but I think that's important to kind of take that in and say, well, if you're doing these exercises, trying to kind of validate that this could be causing some of your pain that you're experiencing, or this isn't related, but it's something that needs to be done mindfully so that we're not creating more imbalance that could change posture.
Agreed.
So,
And I think more often than not, I'm trying to go for neutral, but these are the only two exceptions, when if it is a unilateral sport. They're dominant unilateral sport, I think.
and I would say even, maybe outside of some of the tennis athletes I have, very few people are like, I only play golf, right?
Right.
Well, they're not perfect for sure, but they're also not like, hey, I play golf and I train to play golf. Like that's
Right.
gonna be a very, very small population. The other one is like runners that run like 400 and 800 meters on the track. They're gonna need to be more flexible on their right hamstring because they are running on a slope surface.
Oh,
Because you
never
need more
even thought
space
about
to
that,
clear,
yeah.
right? So it's very small populations where it's like, I can live with this because that is specific to what you do. Where most people are just, I like to play golf, I like to play tennis, I hike, I do this, but like, they're not saying like, hey, this is the one thing that I'm actively not just I like to do, but I also like train to get better at. Runners is the only other thing I could think of, but that shouldn't be unilateral. So, unless they're, like I said, running on a slope surface, running on the beach, not the same kind of
Shot
thing.
put,
throw things.
javelin.
Baseball?
Yeah, baseball.
Baseball
Sure.
players?
Yeah.
Or the single arm, dominant,
Yeah,
cricketers?
any throwing sport,
Any
any
throwing
over, volleyball is gonna be the same way.
Yeah, there you go, yeah, so I guess unilateral sport dominant people needs to be, kind of stay at an advantage on that unilateral side.
Right, without compromising their mobility overall or
Yeah.
putting them in positional faults that are causing some other type of pain or dysfunction.
Well, right, and looking at a bigger picture, not just at the posture, but, okay, well, how is this, your pain isn't when you're swinging your golf club in your neck.
Nope.
Your pain is more sitting, postural, so
Correct.
taking about to function and how it's affecting their function, and, yeah.
Correct.
Correcting.
So I would be less concerned with myself and the vertebral body positioning in my mid-back as I would with, well, at least you haven't checked my mid-traps or low traps. So like, that's where I would be more focused, or specifically the rounding of the thoracic, upper thoracic, because not only does that
Tightness in your pecs, things like that.
right,
Yeah.
that all ties into my positional pain, but it also could compromise my ability to rotate, because if I'm rounding my thoracic vertebrae, it's going to limit my rotation. So that's when I would say to someone, hey, this is not only important for your pain, but it's also important for your activity, and that's the kind of thing I would really hone in on
Okay.
because of that, because it's both pain and function. Because we had a talk with Kevin yesterday, and we're talking about our wellness patients, and specifically, you know, the more athletic ones that get to a point of pain, and really framing it more in the idea of performance. And so for someone like me, I know that's what I would respond to is, hey, you fix your neck pain, but from a performance side, being rounded through here is a mechanical disadvantage. And it's something I know, I just have not been very good at being successful in correcting it. so.
Myself personally,
Yeah.
but yeah, I mean, we're busy people like ourselves, so. So,
You wanna keep going with the testing?
yeah, let's go testing, and then I wanna go into treatment too, because I feel very enticing to
Okay.
take care of your thoracic spine, like I just wanna go at it. So, go, for lower trapezius, just, arms out overhead and raise with thumbs up, that is the manual muscle test, Daniels.
Why?
And you hold. There you go. Hold and fight. Okay, so very strong. I'm gonna give him 4+, but again, very similar pattern. Right side is weaker than the left.
Would you still say 4+?
Yeah, so let's see. For the right side, because give in, I would give 4 and then 4+. Yeah, so 4+. All right, and rhomboids are gonna be, if you wanna bring one arm behind the back, just fully, yeah. And, yep. Now there are times elderly who may not even able to get the arm over.
Yeah.
And so in that case, you would just test it with the arm like that and thumb down into internal rotation, and then make sure that the scapula is going first and hold, and then you ask them to fight that resistance. He's doing pretty good there. And let's try the left. And for the left, let's try this method where he's going as far as he can, and then lead with the scapula, and then has to pick up the back of the wrist off the back.
For range of motion too.
Yeah,
Yeah.
and
I've never done that.
No, I haven't either.
so this one's actually, this is the most standard, according to the manual muscle test in Daniel's book, is the
For
most
rhomboids.
standard rhomboids test. It also reveals how much, it actually reveals more about how the pec minors are and how much they're limiting, and that how they have the inability to do the scapular retraction while they're doing the lift off, and then they have to not be able to touch the back of the wrist to the back with that grade applied at the mid-arm. So keep the wrist
Is
off.
that even possible?
Yep. So he's doing pretty good, but he's struggling.
Yeah.
And, you know,
It's just isolating, it's a more isolated.
very much
test.
isolated. And it's
Gotcha.
considering that he has a thoracic rotation the way he has, considering he has that down sloping on the rib cage, all of that, we knew that it was going to be weak.
Yeah.
In my hypothesis, again, going back to clinical, I may not even test these because I already know a pattern. That he is a younger athlete. We know that his has a musculoskeletal injury, musculoskeletal differentiation, what was that?
Condition.
Yeah, abnormality.
Abnormality.
That we need to just focus on how can we make it better. So at that point, I would just start working on the mobility of the thoracic spine. He mentioned about neck pain, but so much so of the neck pain comes from the thoracic spine.
Gotcha.
And if I've already ruled out any radiculopathy, if I've ruled out any headache issues, any VBI symptoms, eye medical, then I just go straight to the thoracic spine at that.
Can I add two things that I would add?
So,
So the two things that I would add that I think I'd pass it, I don't know. I would look at paraspinal extensor strength and deep neck flexor strength.
Yeah.
So I would do 30-second holds, so I would have someone here or without retract and hold to see if they have the requisite capability in their paraspinals. And then I would also do it flipped over, where you do a chin tuck and lift
Nice.
and hold for 30 seconds as well, to
So
make sure.
you do 30, so is it 30 or 60 seconds normal?
I've always done 30, but
Okay.
I can't
So-
say that that's,
I I think
I can
it's
speak
6
from the evidence.
Yes.
I've
Okay.
read it, 39 seconds for males and 29 seconds for females.
Oh, there you go. All right.
That's the standard.
So, and when in the manual therapy course I was just taking, he teaches that test by putting your fist under their head, telling them to tuck the chin, and they have to maintain the chin tuck
Correct.
and just barely lift off your head. So if they're lifting too high or they lose this at all, then they failed. Because before I was just like, lift your head, right? So it's a very clear,
specific.
you gotta keep the chin tuck and you've got to just be right off the hand here.
And that's not paraspinals, that's the deep neck.
That would be
Deep neck
deep neck flexor, the front deep neck flexor.
Because you see this SCM's not popping out there, and that's where a lot of people will compensate when they're weak there.
It's a randomized controlled trial, RCT.
It almost feels like it's underneath your tongue,
Yeah,
deep through there.
yeah.
Which I am a little bit weak in those.
Yeah.
Well, while you're on your back, so for prone, I would do, you may want to scoot down so your head can be there. But prone, I would just do mobilization manual. But we also noticed that there,
Well, you went really fast through a few things that I think like they might have missed. Like the major like red flags that when somebody came out for like cervical pain, like we want to make sure they don't have radicular pain or VVI. Like, how did you do that?
asking the question if you have tingling numbers.
Right.
What was
Yeah.
that?
That's predictive for the nerve.
Right.
Predictor for the nerve.
You all know what the
Headaches, the type of headaches that they
VVI
have.
is, like
Vertebral body something.
basilar insufficiency.
Yes, yes.
So that would be, I mean, it's rare in our, unless it's an older population,
You want
but,
to show the screen for that?
Yeah?
so, tell me if I'm wrong, but it's just look up over your shoulder, so you're compressing the vertebral basal artery, and you're just, I don't know how long.
I think 10
Is
seconds.
it 10 seconds? You just wanna make sure that there's
3.
no.
30. Okay, I've done 10.
We screen that, that's a big one for if you're testing for vertigo, because you're taking their head back in those extreme. I've read differing things on that, like even if you need to test that anymore, but, and then same thing, so
But it's up and,
it's up and over, like diagonal look over your shoulder.
And honestly, I only test it if I'm going to be doing traction or joint mobilization. on
Right,
someone.
because you
That's a good
said
point, yeah.
before we do thoracic mobilization, we wanna screen, like rule this out,
Yeah,
but yeah,
I
so.
only do it if I'm going to
Or if you're doing like a head maneuver for like vertigo or something like that, it's a screen test. So it's rotation to the same side and extension. It's rotation then extension to the same side, I think it's 45.
cause I don't feel it here, I feel it right in the back.
We're not testing, we're
You're not testing
testing to see if there's insufficiency of blood supply to the brain. So what you would be
On your right side.
on the right
Yeah,
side, so
yeah.
we're compressing.
So if you
So
are
that's-
still standing, which
Yes.
means you are not
Probably don't do it in standing, but yeah, okay.
So I'll give you an example of why it's very important.
Yeah,
I got away with it, but there was a patient where I didn't do the testing and we had been working soft tissue and I started doing a little traction and he was like, yeah, it kind of makes me feel a little bit weird. So I sat him up and I asked him some questions. He goes, I don't know, it could have something to do with my vertebral artery insufficiency. I've had it for 10 years. And I was like,
Didn't even tell you.
dude, you gotta tell me these things.
I had the same guy, he's got a major blockage, and I gave him upper trap stretches, and he's like, that just makes me feel really uncomfortable because I have this blockage. So those are huge questions. Because we're a practice where we don't have this huge medical intake form, like there's major things like that that we need to know that,
Yeah.
yeah.
But why would stretching cause a problem with your, like, cause you mean if you're stretching this side and it's over here, and that's
Well,
where,
if you're compressing,
that's
You're-
where
yeah,
the,
you're-
cause
you're
the
compressing, you're
compressing
cutting off the blood
opposite
flow
side,
to the
okay.
brain.
Yeah.
Correct. So it happens, right? And those are more fortunate circumstances where we're like, well, that's not the response you should have, so let's dig into that a little bit. But it's why it's an important thing to screen, and I sometimes get sloppy with doing that and tend to know
Sure.
what's going on, so you get quick into what you do. But it's an important one.
It is, if you're working on the neck.
The other one I think is a really good one is the Sperling test, which helps to rule in radiculopathy as well. Where you have the person in this position, so if you suspect that it's right side of radiculopathy, but you also say that I would say I had numbness and tingling through here, and you're not sure if it's coming from the elbow, It could be coming from the
We
neck.
should be doing this with me, because I have numbness tingling.
I don't want you to set you off on a Sperling test.
There you go, side bend, and I think it's sequential, so it's Sperling test, it can be positive at any stage. But then you have them side bend,
You stop when it's
And then
positive,
you
you don't keep going, right?
correct,
Okay.
yeah. And then you do a rotation, opposite side rotation, so basically the idea is you're compressing the foraminal canal on the right side.
Mm-hmm.
So, same side bend compresses it,
all
opposite
passive?
side bend compresses it. What was that?
Is it all passive or is it active, like assisted, does it matter?
It will be active at some point because we will need to
Press down.
down.
But with them, are you telling them to relax or are you doing all the movement?
Both,
Does it matter?
both, because I'm guiding them.
I think
No,
it matters
okay.
if it's positional.
Okay, yeah.
Yeah,
Okay.
I
I,
have to leave.
you gotta go.
Yeah, I gotta go.
I'm so
Bye,
good, thanks
guys.
for all your help.
Thanks for having me.
Later. So you go side bend. I think what I'm trying to do is I'm trying to get the right movement.
Okay,
Because they may or may, like, they may not side bend
Sure.
clearly. So I'm just helping them side bend and then rotate. Are we all good, so?
Yep, and then
then you
extend.
push and extend, then push.
Yep, and then, yeah, pressure down through there.
And then pressure from my I just don't like the test. I
I-
don't do it.
I don't like
It's just
having
a
it done.
weird position
It's
of
just
the neck.
hurting people. I mean,
Yeah.
now as far as we are, I think I just go to a lot of hypothesis,
Yeah,
few tests to
I
prove
would,
the hypothesis and treat and test.
I
Well,
don't
how,
use it.
that is pretty sensitive test though for radiculopathy.
Correct.
Like, yeah.
and I would say I use it situationally, right? Like I'm not coming in and
On
like,
every amount,
single
right.
every single neck pain. But if I'm saying it's weird because they've got some forearm pain and they do have this, and like I want to rule out like carpal tunnel or that, like I would use it as a test or make sure there's not an entrapment at the elbow. Like that's those situations where I think it can be really valuable because if you can recreate a foraminal
I like that.
narrowing, it's a really valuable test. But I use it 5% of the time,
Yeah.
less than that maybe.
Yeah. All right, so we got the Sperling. Let's go prone so we can get some spinal mobs. All right, we'll breathe, and I think everybody would want to feel his spine. So the goal is your shoulder and your hand needs to be in line with each other.
Yeah,
Okay,
you
so
showed me this
sometimes-
with what patient were we with the other day?
Yeah. And
Now
then
what, what were you just saying?
basically your line of force, your vector,
Yeah.
when you're gonna be applying the force
Straight.
has to be straight down. I prefer to have the spinous process in the middle of my thenar and hypothenar because I can get the best force and I can also gauge am I neutral or not. This also gives me a feel how he's rotated. So he's actually rotated, as we talked about, right-sided, and I can feel that through just feeling the amount of spinous process I feel in the lateral side of it on the spine versus the left. So these are the things that I'm feeling for. Obviously, I'm not drawing on anyone by this time, but that
Is this a gliding movement? Or is it just pressure down?
it's more of a down up. It is called a glide. It is called a glide. It's called a PDA glide, and the reason why it's called a glide is because you're just moving the joint surfaces.
And that's what
Parallel
you're
to
saying,
each
you wanna
other.
feel the bounce back.
The joint itself, that's the way it moves. It moves in a gliding motion.
Mhm.
So like this, there's
So
different.
there.
Mhm.
So one thing that will help, you wanna show him like the sustained force too, I think that would be helpful.
Okay. So, you mean this?
Yeah, so because what I could feel with John going is like pressing in, pressing out, versus what you feel from being able to sustain the force. I think that's pretty valuable.
I see what you mean. So you're basically, yeah, so like
Uh,
kind of going in, and then you're sitting here and you're feeling for how the spine feels to you.
Right, so it's not CPR where you're in, out,
Up and
in, out.
down, yeah.
It's slow, sustained, and then pressure at that sustained point.
Try it, yeah.
It takes a lot of practicing.
So like when you're in school, you just learn by practicing on each other?
Mhm.
It's not just school, it's like years of experience. I mean, they feel stuff I still don't feel. I've been practicing for 20 years. Don't go up and down. No CPR.
Yeah, that, very solid, there you go,
There you
very nice.
go. Oh, you were telling him to do a move, I'm sorry, I thought he was just.
Yeah.
Still feeling for it, go for it.
Yeah, and that's, I mean, the difference between assessing and treating is a pretty small, insignificant line a lot of times. Because
Yeah.
you're trying to get a sense of, is it moving? Do I need to make it move, or is it moving? Do I move on?
And what is normal movement? What
Correct.
does that feel like?
Correct, and what you'll find, especially as you guys get to school, is that you're gonna feel 40 classmates' spines, and most of them are gonna be moving fairly well, because it's people in their 20s and 30s with healthy spines. It's really not until you've done this with, you know,
And you can feel they're not moving.
correct.
I mean, he's a little, like, feel one segment to the
Cause
next.
like when we saw the patient, we went like that.
There,
and
specifically.
And
Did
then
he
like,
do any of that?
and
see if you
start
can
to
feel
the
any
curves.
different
So you're
from
feeling
here.
for curves and you're feeling
Or-
for
So you sort of flatten right
movement or
here.
lack of movement.
Yep, and if you
Feeling
feel
for
my
lack
low
of movement?
thoracic, I have really great low
You
thoracic
are
mobility.
looking for curve.
You're looking for curve.
You're
and
looking
are
for curve and you're
for
feeling for the movement.
And movement is.
You're
The glide-
feeling for the
What was that?
position.
Movement is.
Oh, yeah.
No. the
So I've got
movement is good.
so
No
much of my
movement
emotion
would be
is
more of a
here.
concern.
Comes from there.
Either. So the way how joint play works, so there's a grade.
So,
So
but then you
it's
start
a grade
flattening, like that's you
minus
definitely can
2,
feel that.
minus 1, 0,
Mhm.
1, 2.
And
That's how the
where my
grade
issue
is.
I have no
And
idea
0
how
is
great
normal.
that movement.
I don't, I
And
just, it's
1
a binary for me.
is
Needs work or doesn't need work.
Yeah.
have 50%
That's-
hypermobility.
There's no,
Hypomobility. 2 is,
I don't know.
I
how
don't even know
grade
how
it.
to grade that
it's
though.
minus 2, minus 1, 0, 1, 2.
I get it, but like that's so minute of a difference, like
Well,
I,
that's-
I told her,
So
even,
Go ahead.
even after doing it, for me, I treat it as a very binary situation.
Gotcha.
Meaning I need to keep working on it or I don't need to keep working on it.
Yeah.
hypomobility of the thoracic spine is
Yeah.
what I write.
Right.
Yeah,
Now, that's not
yeah.
textbook, but
No, I think I also do it that way, but I think when we are asking scale from 0 to 10 for
Yes.
subjective pain, this is
Sure.
how you relate what you feel on paper.
right. Well, just like the tenderness scale, there's a whole tenderness. I
From
actually
1 to
put
4.
it in the eval because it was different than what we were doing. But it's like, do they flinch? I mean, there are very specific
0 to 4.
measures.
Yeah.
I mean, bottom line, when you're in real life, and does that change the way you treat? It's just a measure of showing progress more objectively.
Yeah.
Yeah.
So for you guys, I would say, one thing I was just talking about with Sarah, if you guys show them where like T8, T9, T7 for me is very mobile versus T3, T2,
So let's just count how many
just
we
feel the
have.
difference between those two segments.
So that's C7.
Do you know how to know where you are on the spine, like landmarks?
So this is C7, right? I just marked.
She says.
How do you find C7? How do you know? It's the most prominent, so if you come down and then that spine is processed, that, see if you can find it.
It's the North Star.
Yeah. Those are things we just take for granted that everyone knows that we
It's
don't
true.
know,
You
yeah,
got it.
when you do it for a long time.
Find it on John Haley.
I think I did it.
Mhm.
Well, John's is like really, like, right.
Ready to go?
Yeah.
Yeah, I can feel mine easily.
Find your own selves.
Let's see.
It was tricky.
He really
Ooh,
goes
okay.
concave for, around
There.
Yeah, that's right.
here, right, drop off here. Like
Yeah.
there's a
Okay.
flat segment.
But why isn't it?
And
This
his
one?
sternum is prominent there, so.
The top half was
Yeah,
flat,
it
but I
was, yeah.
didn't really
Think
look
But
at
about
why
it.
isn't this one since I like feels very very prominent to me?
It's a good
Yeah, so
point.
it's
It probably,
So the most prominent, she's absolutely true, but I don't think that you check that in this position. You do it in sitting. So the most prominent in sitting would be,
Make more sense.
because it is,
This is
sort of-
C7 right here,
So
yeah.
like,
yeah.
Yeah, that's C7,
But it's apparently not so prominent than the T1
yeah,
in this position,
This is
and that's throwing
T1.
them off.
yeah.
That's throwing you guys
So
off.
the spine of the scapula, the
mhm.
upper border is usually T2,
Oh,
Right.
you're right.
T2, and then the inferior ankle is T7.
Yes.
So those are just good landmarks. And you can go Google that, and I have it on my phone just for reference. It's a great, especially when you're needle, like if you ever needle, it's really important for certain muscles and insertions and organs.
Right, so the goal that we were trying to get to was comparing the hypermobile segments and hypomobile segments. So let's say this is T7, is it 1, 2, 3, 4, 5, 6, 7?
Yeah.
Alright, so try to palpate there, down, up.
Just feel the movement right over it.
Just release him, or is that the bed?
The bed.
Okay, now compare this to right here.
You should be feeling more movement up top.
It's hard in here.
Ah, like that.
A lot harder.
Not harder to, yeah, see how it's
Oh.
easy?
Yeah.
So easy? Yeah.
So you would grade that as a 2, normal movement? Do you grade it in?
0 is normal.
Oh,
What about
2 is
negative?
hyper.
Yeah, 1 and 2 is hyper.
Oh. I see.
And -1, -2 is hypo.
Okay.
So it's 50% and 100%. 50% and 100%.
Is hyper
One,
good
two.
or bad?
Wow, can be bad.
None of them is good. 0 is best. Like,
Yeah.
you want just right joint play.
But
Well,
what, it compares to
but-
what?
I would
Overly
push back on that.
Yeah,
Okay, okay.
yeah.
So for someone like me, if I was able to have some thoracic hypermobility,
Okay.
it allows me to rotate further for my swing,
Mhm.
as long as I have good stability as well. Like
As
if I
long
have-
as you have good
If
stability.
I have good segmental stability and have been training my obliques and multifidus and I have good core and trunk strength and I'm also hypermobile, I think that is excessive range to be able to utilize.
I like that.
It just is what
Very
it
clear.
is, like, I mean, you could film me, I mean,
Yeah.
I'm hyper mobile, we're not gonna necessarily change, I'm gonna have to strengthen to stabilize, but that's not necessarily gonna ever change the joint play,
Correct.
right, so.
Correct. Yeah. Yeah. All right. Let me add a couple treatment moves right there. So, by the way,
So how would you put this on paper, what you're feeling there?
I would say hypomobile segments at T4. I mean, his is like
Lower,
T6,
T7,
7,
okay.
6, 5, 4, 3, 2. I mean, his
Hypo is low, or is he more
Hypo.
normal,
No,
lower?
he's like tight. So
Low,
hypo.
okay.
Yeah. And I would say grade -1, right? So I'll just. You okay?
Mm-hmm.
All right. So this is grade 5, right? Glide. Take a nice deep breath. And I'm trying to go towards his eye, and then we're going straight down, which I didn't get a release, but we'll just keep moving up.
But you're still effective if you don't get a release.
Yeah. All right. And let it go. There you go.
Alright.
I needed
Did you
to
get it?
rotate. So
Why
I
did
was
you
doing
rotate?
hand rotation.
Okay. Explain the rotation part to me.
So the glide is actually where you are holding the transverse process of the upper segment on the.
Lower,
I use the top upper,
okay.
the upper vertebrae, and then the transverse process of the lower segment, and then I rotate, and I was rotating my hand, but I wasn't rotating with the body, and he's got a lot more play on his skin.
Okay.
He's got enough transfascial movement, which not everybody does, and I'm used to just going this way, but going full rotation allowed me to
Take
get
out
my
the-
hands almost vertical in line with my with the spine.
Okay.
TJ, anything specific?
I think the rotation of the skin makes a huge difference.
And whether you release or.
Just in everything, because you're going to get a much better grip and control, and you're gonna be able to
And I'm
take
not
up the
tall enough
slack of
here,
those segments.
like I have to be up on a, okay.
So I would move your body. Because as much of play on his skin that he has, it's hard to just use your shoulder rotation
And then,
to keep going, keep going.
okay. And I would need to be higher with
Yeah.
my arms
You want-
straight, but
Let me
You
get
ever
you.
stand on a,
always,
Oh.
because we don't have high leg tables.
You know one thing you can do, Sarah, is now that you have the table, you can just set it low. Have you done that?
Wow,
You can just set it up at your setting.
that's true.
So I want to still do like some on the levels right here.
Okay. You do.
So like as in a hypomobile segment, so I would treat it, so that's what I meant.
When I get up in the higher thoracic, I have a harder time with this mobilization, because I go that way.
I actually do
Yes,
this move
me
at
too,
that point.
okay, I do too,
Yeah.
okay, I was wondering, so more
Same thing.
is you too, so like below like T3, this area I usually do that.
Yeah,
Yeah,
that's
okay.
right. The other position that has worked, I switch sides, I'm just learning myself, but I end up switching sides too because then I'm already fatigued there, so like, and then I just go full range that way. Or I can just go use body weight and then mobilize this way.
I felt like I got more from the first way you showed it.
The first one?
Mm-hmm.
Alright, let's see, let's give it a try. So take a deep breath in. And let it go. Ah,
Got it.
yep. Yep.
Next.
Let me do one more neck and then let you come in. So, can I do it in supine?
Yep.
Can I do the rotational glide? You'll have me.
Yeah,
Don't have BBI.
I don't think I've ever gotten a release.
So you wouldn't do
of that.
any like facet joint mobs with them or anything like that, cervical? Yeah,
I would
yeah,
probably look and check that.
Yeah, I would do it for TJ because he has that forward head and he's been in that position. So meaning that he has built, what do you call it, the adhesions around the facet
And we did
and that is, actually this is the facet joint glides. The great
like
glides.
lateral,
Yeah,
okay,
yeah,
you're
they
doing
would
grade
take
5.
Grade
so
5,
I
I
was
can
just
have you
gonna-
scoot up a little.
I don't feel comfortable
Little
with
more.
grade 5 cervical modes at all, I don't.
One more. So the comfort will come with practice.
Yeah.
And for practice you need safe, healthy models.
Yeah.
So I can be one, and maybe we can have Haley and have John. So what I'm feeling for, and you can do the other side if you'd like, is I'm not gonna do it just yet, so don't feel too nervous. Go ahead and relax. So I'm feeling for an end joint end play, which basically I'm just moving and he's just going. So he's hypermobile going left.
Cervical. And we would have already measured like cervical range of motion and.
Yeah, we
before
would have,
treat- yeah.
measured and which side do we need to release.
Mhm.
But what I was going to say was, I am not only side bending it, but I'm also rotating and flexing it.
Right,
And then with that rotation and flexion, I'm looking for play where I feel the resistance. This is where I feel the resistance. And in his case,
I'm actually hypermobile that way, I think.
this way, right?
Yeah.
Yeah. And before releasing this segment, I would release this segment first. If I was to still release it and if it was more tighter, just based on the feel that I got, I was just not comfortable releasing in the left side. Should I try that right?
Yeah, let's see what feels right.
okay.
Yeah, let's just go ahead and relax. Yeah, I can go ahead and let it go. Let it go. There you go. I can see it by his SCM that he wasn't fully down yet.
Relax, oh,
Yeah, he's quickly
yeah,
let it
guarding.
go. Let it go. Take a deep breath in. I'm not gonna release.
Okay.
Okay. I see his legs are nervous, everything. Yeah, I'm not gonna release. I'm
Okay.
just feeling for joint. I want Sarah to try. So
I'm not gonna release it either.
yeah. So here's the resistance, and he's not.
But why
Even
would you
full-
mobilize it if he's hypermobile there?
He's not on the.
Oh, he's
I'm
not.
hypermobile left, but I'm not right.
Oh, gotcha,
And
okay.
he's hypomobile.
And
Okay.
what I do, because I don't do grade 5 on cervical,
Yeah.
I take people to that range
And glide.
and mobilize them
Yeah.
in that position.
Well, right, yes, okay. That's what I do too.
Yeah.
More facet, lateral guides, okay.
So release
Are you
like
good?
a big
I
crowd.
like to
Yeah.
feel it.
Mhm.
It's like
Good.
taking it at the end range and that quick, yeah. All right, relax.
I have to go
You gotta go.
soon.
Oh, yes.
The location is only 9 minutes away, so
Oh, you're
I'm kind of
right.
closing out.
Okay.
I know it's gonna rain because of the event out
it right now yet?
Hypermobility.
No,
So
I've been
I would
waiting for
take
the email like it's
Yeah.
canceled.
my
How
job
did
here.
it-
No email?
No.
No, I've been looking, I'm like,
Like this.
please, email.
Email.
That was my classmate.
Oh, right there.
Mhm.
To see if it's canceled, I was like, I don't know.
You feel it?
Yeah, I feel it. And so you would just take, but do you hold at the jaw to mobilize for that?
So for mobilization, we had to practice, I mean, you're doing just fine,
I mean, I'm still, yeah.
yeah. I will say it's not set up for grade 5.
Oh, no,
Like your
I
hand
wasn't
position,
trying
so-
to say,
yeah,
yeah, I was just.
But what we had to do is
So
we
like
had, we just were playing ourselves just to kind of get that fast motion,
Yeah.
Yeah.
just this motion.
Okay,
Observe.
I would feel what it feels like compared to my left side.
okay.
Great glide too, right there.
Yeah, that, oh, yeah, I see a huge difference there. Oh, yeah,
Hyper-
there's nothing.
Yeah.
Okay, yeah, and just feeling that difference is, you wanna feel the difference?
Oh,
No.
here we
Let's go.
I'm not gonna like mobilize the spine,
You guys
go. In
are,
that movement, I don't
You're just
think I
relaxed.
know enough for
you'll be
that.
fine, I promise.
but
Ah,
yeah, the
nice.
chin
That's a
tuck,
good glide.
the side is
Which
good.
side is tighter? Is this?
This side. Mm-hmm.
Yeah, his spine doesn't go that far. Or the head doesn't
Here,
side bend
Keep
that
your
far.
chin tucked.
And when you glide, you're definitely trying to move the joint to add that synovial fluid. or-
Yes, the synovial fluid in the
Getting
in the,
joint play there.
joint play.
Alright.
In grade 5, you're also adding like the cavitation.
You know, I've read articles lately saying that that really doesn't change the effectiveness of the mobilization at all.
Yeah.
Some of the new training, I mean, I know you can read articles that say everything, but yeah, because it's really just that release of the gas within the
Yeah.
joint.
Yeah.
So, I don't know.
Right.
Because you were telling me that there is an increase in the, I don't know, the effect, oh,
That was a ruse.
Good.
I mean, I do it, I do it to myself all day, how pretty tell, I'm just like, eh, yeah.
So that your head is
I
supported.
guess people like practice
Yeah.
and stuff.
And occipital, this people love, like
What's
an
the best?
occipital release and distraction,
Yes,
cervical traction.
occipital release and distraction.
And first rib, do you do it in supine at all, or always?
I've
You
done
do
it
do
in sitting.
I
Just-
prefer sitting, but I do both. Because the nice thing with sitting is that I can then immediately go into another, yeah, right.
So he's on first rib there.
Mhm.
Mm-hmm.
Do you realize how high your first rib is?
I heard it in class, but I didn't think I couldn't make
Yeah.
a connection that it's
It's up here. I mean, he's up,
first rib.
yeah, it's above the clavicle, it comes above.
You get to it from
Oh, I
here.
thought it was like high, like under the
So
clavicle.
it would make more sense that way, but it
Mhm.
sits so high that the kind of posterior aspect of it is actually above the clavicle and
Oh.
deep in through here, so you get to it going down this way. You can come feel it if you want to. It's skinny enough where you can kind of feel it even just with your fingers there.
No, you're so mean.
Oh my goodness.
Yeah,
But
so,
that's first rib.
yeah, and so for me, I usually use the butt of my hand because I can drive with more pressure than versus like sticking a thumb in. So
And
you can
wanna
kind of
save
feel it
your
on there.
thumbs, especially when you're
Exactly.
hypermobile like me. Oh, super hypermobile,
Come
yeah.
towards the base of my neck just a little bit.
So
Yeah, right there.
set joint.
And you go down that way.
Yeah, towards my feet.
So you will have to switch hand.
Put it like here.
Go ahead and have a seat.
Yeah. How do you see it?
Yeah. And you feel how there's that like firm resistance there, but it still moves a little bit. So that's the first rib. So that's the mobilization for it. So if you have someone, because of what runs between the first rib and the scalenes is, you've got nerves, vascular structures that run through there. So if someone's tight or restricted or has first rib abnormality, it's really important because anytime they go to lift their arms over their head, they'll end up getting some type of symptom there.
You know what this is?
Sounds
Masculine. Masculine.
Is this muscle?
No.
What is it?
That,
Is it
the vein.
It's a vein.
Venous return.
What's the main?
What's the name of it though?
Y'all can think on it a minute.
You're gonna know once they say it.
No, it's not
No, carotid is the artery though,
right.
so you're close.
It's carotid artery in the vein. It would be.
That feels good.
Hmm.
Jugular.
Oh.
You ever seen somebody's neck slip?
Yeah. Jugular.
Neck slip.
Slit.
Alright. Cool.
Alright,
You wanna go on next?
Sure.
You can treat her.
306.
I think next.
My teacher can.
All right. You need what?
My teacher
My
can.
natural
So I
level?
have a video
yeah,
to
that, actually that
Very-
manipulation.
Did it?
Uh,
So your pain is on the right side?
And it's outside. so
Okay.
Yeah.
So what are we doing? You wanna test?
Yeah,
it?
so you mentioned you have tingling numbness.
I just kind of.
Yeah. It started when I started doing handstands, like,
Yeah.
shoulder issues, the left shoulder. I've had a rotator cuff repair on the right, but when I started here, a lot of like overhead, so I have a positive NERS, like overpressure. Well, I didn't even make it happen. Like the cluster is probably, I have impingement definitely, well, there's probably some rotator cuff stuff. But the treatment, we found that I could get overhead without the shoulder pain. So I can do handstand push-ups, and that's what we had added. But when we added those, I started having a lot of radicular symptoms.
I wonder how is your head position when you do that?
You wanna watch?
That's it? Without shoes.
Stable.
So see how you extended? Yeah. Yeah, tuck your chin more. There it is.
Okay. It's probably not the best exercise for me too, since I've had the wrist.
Do you have ganglion cyst there?
No, I tore my TFCC, and so I still have some range of motion issues. So it's probably not the best exercise.
I would say
Yeah.
you should be able to rehab to do whatever you want to be able to do.
I know.
However, that's a complex
However,
one.
right, so
I would
rotator
do-
cuff, and I tear things easily, so, because I'm so hypermobile. But we were trying to get some overhead strength stuff in, and I used to do tons of yoga and inversions, and I would love to get back to it, but every time I try to do a lot of overhead stuff, push.
I think you'd be
weight-
fine with this.
Yeah,
I would do it with this if you
Okay.
still wanted to.
yeah, it's not that important to me. Or we could just do it a little modified, so I could put my feet up onto a block or something, or,
Yeah. But again, look at your head position. Yeah. There you go.
Yeah, that's definitely better. Oh, my triceps when I do it.
Nice.
Every week, yeah.
It's really good. I will say your head is more flexed than tucked. Yeah.
Yeah, that looks a lot better.
I think that's all what it is.
My head.
Cervical position, you were in a ton of extension.
yeah. I don't know if I always am when I'm doing it, but once you said that, I knew, okay.
Yeah.
But when I'm doing push-ups, I'm not,
Try it.
and I'm still having,
Do you do a little bit of cervical retraction and tuck when you do push-ups?
I've tried to recently, but let's see. Now that you said that, I'm definitely,
Aware. Oh yeah, head is the lead.
Which is funny because
That
you
is
don't have that in standing at all, or any significant. The other thing that I think,
Significant lead.
the other thing I think you,
oh
Yeah.
yeah, okay, I see that now, okay.
the other thing I think you'd benefit from is I was talking with
Mhm.
Sarvar with this when we were doing the bench press, is that scapular engagement.
Ah, I like
I'm gonna
that.
do a
Yeah.
little up the shirt so you can
Yeah.
see. But basically by kind of locking in the shoulder blades, that's gonna help get you to a lot more stable position. So if you're here, almost feeling like you're retracting and would be downwardly rotating your scapulas before going into it.
Okay,
It helps you to kind of sustain that kind of locked position when you see your shoulder blades internally rotate
I have
like
a
that.
sports bra on, y'all, you wanna see?
Yeah, let me take
Okay.
a look.
I think I do. That's it. Oh, well, it's all the same. Alright. Once you've been to PT school, you've seen it all anyway, right?
That's correct.
Okay, let me just start here.
But
Yeah, so and I would even, yeah, you feel that difference?
Oh, yeah.
You
for
feel so much
sure.
more stable there, so you're basically just engaging
Oh,
the stabilizers, so that you're not having
I
to use.
feel tight in my pecs when I do that.
Because you're
Can you stay there for a
lengthening
second?
But you're also, if you think
But,
about it,
that's serious, but let Tina finish though.
so
Well, I can't stay there all day.
so the stabilization demand of the cuff is so much less when you're using your rhomboids, serratus, all
Oh,
of your
wow, because I
scapular
was
muscles.
putting so much
Correct.
on my rotator.
Correct, so it's the stabilization has to come from somewhere, so by engaging
Oh, wow,
that
that's
engagement
huge,
of your
yeah.
back, it makes a huge
Well, and I
difference.
could do it a lot more.
And the other thing
Yeah.
is, you're also opened up more, so you've got more subacromial space, right? So
Right.
you're not rounding in with that activity, you're staying more open, and you're letting the shoulders horizontally adduct from an open position instead of from a rounded position.
Okay, so let's carry that over to a plank, because it bothers me there too.
So the cue I love, someone had told me was feel like with the push-up, it's feel like you're screwing your arms into the ground. So with the plank, it's no different. Feel like you're screwing your forearms into the ground and feeling that engagement in your scapulas.
Because, so I've always done more of like a scapular protraction with the plank. So you're telling me.
I would go the other way and engage them, because if you're protracting, we're using serratus,
Serratus.
but that's it. Versus a more retracted position, you're going to have mid-traps and rhomboids engage as well. And serratus is
Okay.
already having to work because it's pushing the floor away.
Okay, gotcha.
So I would say
That just feels so
I have not done
awkward.
these kind of push-ups ever, myself or
Yeah.
train anybody, because I've always thought that this is a great position for serratus and we should use it for that only.
Yeah,
So,
I
that is
teach
a very
people
good
the
learning for
opposite,
me.
yeah, me too.
I should use that.
I think it creates more subacromial space and a better stability complex.
Nice.
However, I had a patient the other
I still
day,
had to have you do one more.
Sorry.
Yeah.
I had a patient, this is when we should have the mat. I had a patient the other day though, who has a lot of subacromial position. I changed her because she was trying to do
Yeah.
her stuff at Pilates with the shoulder blades down and back and was having a ton of pain because she's hypermobile and it was pushing her humeral head forward. So we were doing more of like a scapular protraction, which decreased her pain because she was doing this versus like I had her come more
Where
here.
almost like she was doing a dip and she was.
Like she was just loose, because you have to really engage. I mean, you have to have great core strength to keep this. This is
Right.
what I'm noticing. Like when I do this, I'm wanting to hyperextend or
You're almost
anterior.
you're locking out.
Yeah,
your
you're having
joints.
to really lock in and put. I mean, that's a ton of stability because I'm hypermobile there and have a lot of low back pain. So for me to even do a plank in that position, I feel like I'm going into an anterior pelvic tilt.
Hard
It's
to.
that, maybe it's like that balance,
Yeah.
you kind of use both.
Yeah.
Because
I don't see why not, but I think it's a motor control thing too, where
Like right
Wow.
here, I feel neutral. Like
Because-
this feels like way off. This feels like definitely scapular push-up. But when I'm like down, like that feels. In the push-up, it felt great. In the plank, it feels very odd.
so I would try exactly. And how do you feel there? Because
That's hard. Like, cause I've never trained it that way.
Yeah.
I'm more like this.
yeah,
Yeah.
I mean, realistically, I think there's
Yeah.
probably value in both,
Yeah,
right?
okay,
Like
yeah.
You
Yeah.
should be training in multiple positions
Sure.
and
Oh, that's why I was able to engage a lot more triceps with the scapular retraction, and it definitely took pressure off my shoulders. So that's good. Now, right now, I'm not having any tingling. It comes and goes, but
is that how it typically would have been here
And
by
it-
now?
I don't even know. Like, it's not like this ooh shooting pain. I'll just notice at the end of the day, like all my fingertips just feel a little numb. Right now, they don't at all.
Okay.
Do you want to do the Sperlings? But you know, when I treated myself,
yeah.
I think it was, I don't even know what muscle.
As
Brachialis,
hypermobile as you
Yeah,
are,
it-
you don't have nerve.
Yeah.
You
Yeah, you
are
don't
have
think it-
position.
Okay.
Yeah.
Can I have you
probably-
do one last thing?
Yeah.
All right, so go to the push-up again, the way how he taught you.
On
do
my
it.
toes, or can I do it on my knees?
Yeah.
Okay. All right.
So exactly how he taught you.
Okay.
Yep. And go all the way down and hold. And check how much, yes. So try to tuck it further, like, yeah, from the neck, yes, yes.
I'm feeling a lot of tightness, like pec minor.
Okay.
That's where I'm feeling it, right
Okay,
there, when
okay.
I try to tuck.
Good,
Yeah.
yeah.
Okay.
I wonder if it's almost like, you know, like when you do like a single leg deadlift, how you like feel the opposition.
Yeah,
I think it's a lot of what you're feeling is when you're taking it eccentrically
yeah.
and you've changed that position, because really,
This
not
is
only are you
corporate,
retracting, but
yeah.
you're posteriorly tipping.
Yeah.
So we're taking the length
And
of that
stretching
pec
it.
minor,
Okay.
and then we're stretching it while utilizing it. So it's
Oh.
almost this eccentric
Work,
action,
wow.
just like the hamstrings are. I like that a lot for you.
Okay, gotcha.
Yeah, that's all. Good,
Uh,
so,
But that's how we treat people. Like,
It's,
I mean, all these tests and everything are great, but when you get into what treat people and then we look at exercise and what they're doing functionally and just tweak it,
yeah,
that's big. I had
It's-
sun poisoning all over my chest, that's what it is. Like, isn't that horrible? Anyway,
I say, I usually get that once a year.
I've never had it like this, I have to use a steroid right now.
But there's a ton of, I guess the trial and error is not the right word for it, but it's test and retest. So
Yeah,
when they were looking at me, it would be measure it, go through this thing, and then remeasure. Because that's confirmation that, hey, this is an impactful treatment for what we're looking to accomplish. So I think that's a huge part of it, because it's never like, I put the whole puzzle together in this like checklist order. It's, I found a bunch of pieces and I started putting them together, and then that's why we see people for multiple visits, and you start kind of getting a sense of what is working, what's not, what has been missed, or what is now showing itself that wasn't before because of compensatory patterns.
can I get you to knock out my thoracic spine really fast?
Absolutely.
and then can I get you to try some grade 5s on my neck?
Oh,
Me?
I thought you said you
Either
did
of
very
you,
fast.
I will. It's been a while.
Yeah. Well, I will walk you
Do
through.
you guys wanna feel my spine and see if you see a difference?
John?
Yeah.
315. Get some more. Where did I put my coffee mug? Shaz took it and
Just
then.
move up. To see, like, you're just, that's okay, moving up each little segment and seeing how you feel it move. And I mobilize really easy, so if it pops, you feel a difference there from
I
below?
think this is like very mobile versus the.
Oh, really? Okay.
You feel the difference compared to with me? It's hard because I didn't feel my spine.
No, I know.
It's hard
What
to,
do you want to feel?
it's hard to tell.
Yeah, I agree.
It
I mean,
takes
it's in relation.
1,000 spines to get a feel for it.
See, that hurts. No, that's okay, but that lumbar sacral junction, you're doing lumbar spine now.
And so if someone told
No,
me
you,
that, that's information that you're processing. So it's, okay, they don't accept that well. So you're taking not only their symptom, but what they felt, right? So it's
you need to
functional or
go to the
dysfunctional.
end of the joint range, so push down more until you feel a resistance. Yeah.
And then once you have that, it's that very small kind of percussions there. So you're taking up the slack within the joint, and then you're doing those small percussions.
That's
Something that
actually-
takes a lot of fuel for, and I think maybe we take for granted.
But you're doing great.
Yeah.
Like, that felt really good. You were,
Exactly. And everyone's gonna find the hand position that works best for them. They'll teach you one, and everyone else will find something else.
so while you're pushing down, don't let your hand slip up.
And
So,
that's,
yeah.
and that's why, so I'll show you what I personally like. I'm gonna just go
Yeah.
somewhere where I know you're gonna respond well.
Yeah,
That's why I like.
right at the brow line for ladies.
Yeah, and
So
then you
you're
can,
using both hands to.
because then I can also do a little bit of this kind of skin lock with her
Mm,
and take up the slack there
Oh,
and
so
then
you're not-
mobilize her there.
moving forward as you press down.
It's the forces through here, I usually go almost straight down, but it's slightly as you get higher up, more towards the eyeballs because of the orientation. So once we leave the lumbar spine,
the,
Where's the spine?
yeah.
That's fine.
So, you can see the difference
Couple videos as you.
in the orientation of the vertebrae. So as we get through these bottom 5 segments with the facet joint orientation is here, where you can see this angle. That's going to allow for flexion and extension, so forward and backwards bending, and a little bit of side bending as well. But you can see the difference with how kind of stacked they are this direction versus as they come out here. They're almost more like dinner plates stacked on top of each other that are going to allow for rotation. And as we get higher up, you can see the difference of what that kind of upper thoracic compared to this lower thoracic, the difference is. So as we get here, you're going to respond more to this motion versus here, it needs to be a little bit more superior in direction. So you can kind of play with it a little bit, you'll get a sense of what each feel like, but understanding the orientation of the facet joint that you're trying to move makes a big difference. So like when I come here, she's gonna get some benefit from me going straight down, but she may not get that same as I come up here, so I need to change that angle slightly because of the.
Show them where you're putting your hands, like when to
So
mobilize.
when I come in for this, I'm here and here.
On both sides.
Yep. And I'm right on top of that, so you can see I just did a really good mobilization there. Alright. Oh, no, that's spot for that. Yeah, I gotcha. Are you having it higher out?
Right, right in there, yeah. And that still carries through to that sort of strain pain in the sternal area. Remember me having that?
Yeah, is it still persistent?
Not as much. This table's
Almost too soft for somebody who's hypermobile. Have y'all know, well,
for me, like it's almost too much give.
In the table?
Yeah.
Alright, I'll have you breathe
You
in.
got a firm one, right? Switch it out.
There, it went before you even.
You pressed it.
Yeah.
Oh, wow.
Yeah, it
Nice.
went.
That's easy.
what were you saying? Oh, yeah, it's not anything like it was, but I definitely still feel it. And was feeling it with a push-up, so that compressive, there's definitely some sternal component
And I
there.
feel it's most related to the thoracic kind of vertebral.
I don't know. But it's just even still tender to push there. Like,
How did you feel with like doing these like clavicular mobilizations?
Yeah,
it's just
Yeah.
not.
There. You mind if I do a sternal one next?
No, I don't want it off. That, oh, that's like super painful.
Okay.
Like it feels like it needs to pop.
Okay. And do you feel it at the
Oh.
SC joints?
And then when I take a deep breath in, I feel it just all along, like yeah.
You mind taking a few deep breaths in?
I think it's hard for me to breathe deep too. Like my breathing's weird.
Diaphragmatic breathing test.
What does that look like?
So that is measuring the circumference of the end of the exhalation to the end of the full inspiration and the difference. And I think it's like 3.5 centimeters is normal versus whatever
Huh.
maybe in your case. Yeah.
Yeah, but it's.
How did-
What was that?
I don't
How
know,
come
because
you
I
know
don't
so
know,
many
because he's a
interesting
teacher.
tests?
But it feels like
Head to toe.
relieving, but it feels almost like, I don't know.
So this is what I feel like in your case, because your ribs are going down this way. And if you're pressing down, then it's only adding more compression
To the joint?
to the joint. That in your case, we almost need to pull it from the inside. And the only way we can do that is we can use the muscles as levers
So we
and
were
do
doing
a
that.
hold relax in a
Ah.
full open position, and then have the clavicular fibers off the pecs do almost like a
Like a-
closed chain
Muscle energy. technique.
muscle energy
So
from
like
the
from,
proximal segments.
so like very wide.
Or even right here.
Like-
Yeah, that
Yeah.
would be self. That would be self with a little muscle energy.
But just the stretch,
No, so
No.
then feel like you're doing a resisted pec fly. So almost like the
like the little thing we have, right? The pec thing, the squeeze, or no?
Now that
You
is too
gave me
narrow.
that
Yes.
before, but
Yeah,
yeah,
that-
okay. I feel a compression when I do that. I feel that same compression, okay.
But we want to do it in a Lenden position because the angles are important. You
Okay.
can do it from here and
But,
it will still pull, but if we had it wide open,
okay.
think of like a,
Oh, I can already tell that's gonna work, just in my head.
so if we were to isolate clavicular fibers, you have to be 45 degrees scapula. That, yeah. Like here. Versus up top is sternal fibers.
Would have never come to my brain.
Yeah, that's a good point.
Yeah.
And at this point, we can relax the scapula. So what I see is her scapula is anteriorly tipping right now. And
Which makes sense with the tight pec minor
the
too.
tech minor, and even like in this range. So what I would do is I would bend both knees, go for bending the knees so we can relax any tone and tension in the thoracic spine. I'll probably add a little bit of cushion under the neck so we can increase tension from this angle. Yeah, so that's a little more relaxed. And then I would relax the biceps at this point, like here. So the biceps are not taking over, but for now we'll just let it hang. All right. So from here, I'm gonna ask you to, for the time being, left arm. Lift this arm straight up like that at a 30% force. So yeah, and just hold.
I feel like this needs to be stabilized.
Okay, so we would do both together in that case. So we just do this and go for it. Yep, and just hold. And then slowly release. So go ahead again and hold. Now keep pulling further. 60%, 90%. Yeah, and then let it go.
I feel a strain, but not the same compressive pain.
Yeah, because this is going to be where the fibers, let's think about the anatomy, and if the fibers are attached right
Pulling a
here.
dent out of a car.
Yeah, just pulling the dent out of the car. Because we want to go the reverse glide.
Yeah.
We don't have an access from underneath the
Yeah.
sternum.
You want to try one on each arm? So you can get a little more force.
Together,
Mm-hmm.
90%. Go.
Yeah, I feel like it would almost pop. Yeah, it's like
And
that.
it should.
Yeah. Right, okay,
Go for
let's do
it.
it again.
Yeah, let's get a pop.
Okay, everyone, I have to go.
Oh,
My kitchen had been canceled, so.
That was it.
have a
Okay,
good one.
bye.
Thanks for
Good having you.
How does that feel?
We read
Repalpate?
Yeah,
I'm not going to be as
force.
forceful. Your sternum is more prominent than it was.
Go a little more. It's definitely right there, I still feel.
So then when we want to maybe do some sternal,
Some sternum fibers, yeah.
So-
And then even middle fibers,
Yeah,
like
okay.
these fibers.
I would build up to it with the 90% probably.
Just start with like
Yeah.
30.
Just because of the vulnerability of the shoulder in that position.
Now I'm feeling numbness.
So,
You're like it was almost like compression
Compression.
here. Yeah, that was, yeah, that's
so maybe compression, yeah.
yeah.
Because this kind of do a web on top of the
Maybe
biceps.
bicep, yeah.
Like here. Yeah.
It's definitely what it needs. It's funny how you know, like,
You can feel
yeah,
what
you can
feels.
feel it ready.